expert comments. I would start with the paper read by Himanshu Pandey about randomized controlled trial about robotic-assisted versus open partial nephrectomy. There is no doubt that ever since the robotic surgery has come into vogue, the incidence of partial nephrectomy has really increased. We were hardly doing any partial nephrectomies a quarter of a century ago, but ever since the robotics has come, more and more centers have started looking at the partial nephrectomy part. And I think that is important, but having said that, it sometimes comes across my mind that when it is like that, then why should we need to compare with open at this stage, 25 years from now? The second paper was about the cancer-specific mortality in T1 RCC. Again, the same thing. If we are surgically much better evolved to do partial nephrectomies, then there is a very little percentage of patients who would require a local tumor destruction and not go for partial nephrectomy. And those are the ones where perhaps there are medical reasons rather than surgical. Coming to the off-clamp, on-clamp robot-assisted partial nephrectomy analysis. Now, there is a fear of partial loss of GFR versus a complete loss when you convert a partial into a radical nephrectomy, as was shown in the Vatikuti trial. So obviously, you need to be, it is like penny wise, pound foolish. So you need to be careful that if you are doing an off-clamp partial nephrectomy, there is a significant and a definite definite incidence of a conversion to radical nephrectomy. I would put in a caution here. Suppose you are doing a partial nephrectomy on a medically challenged renal disease. For example, a GFR of 2.1 with medical renal disease, and there is a mass which is malignant. These are the patients in whom the ischemia is not taken very kindly by the kidney. So if you clamp the vessels and when you unclamp the vessels, we are not sure whether these kidneys will revive as good as normal healthy kidneys. So these are the patients where you may try off-clamp. And another thing is when you do off-clamp on these kidneys, they do not bleed as well. I've done a few, so I can tell you that's because there is a glomerulosclerosis. When you're doing a partial nephrectomy off-clamp, they do not bleed as much as healthy kidneys. So these are my expert points. Thank you very much, and over to you.
Thank you so much. So I'll just talk about the Fast Track 2 study. Actually, the patients who were inoperable in kidney previously, you just were subjected to palliative form of therapy, either in the form of palliative chemotherapy or palliative radiotherapy. So this was a nice and a wonderful attempt where they tried with SABRE, only those patients who were inoperable. So what they found was they're expecting was some 90% local control rate, but what they achieved was they got 100% local control, which was a wonderful. So second thing, they did not have much of the toxicities also, as only one patient needed dialysis, and that too also had a lower GFR at baseline. So considering all these factors, it gives us a food for thought that whether a randomized attempt with surgery can be made in the operable patients also. So another study was this Checkmate 914. Of course, it was a negative trial, so they wanted, so in high-risk features, RCC, if they could add adjuvant therapy with the doublet of nivolumab, but unfortunately, it was toxic also, and except for the sarcomatoid variety, they did not do well. And they tried with single nivolumab also, but unfortunately, it was a negative trial. So we have to wait to see whether, but only we can say a positive thing was PD-L1 positive tumors did a little bit better than the others. So with this, I'll just wrap up this session, and thanks to all the speakers.